Thanks so much for having me. I'm here to present the results of the COVID-out trial, a phase 3 randomized trial of acute outpatient treatment using repurposed medications. The trial was funded by foundations, so trying to scrape together money from different foundations quickly in the summer and fall of 2020. I did receive placebo pills donated for the fluvoxamine and ivermectin, placebo and active med were donated as well. I'm funded on a KL2, then K23. I have no financial disclosures, and I'm not an infectious disease doctor, so you'll not get a lot of insight into mechanism from me. All right, so thank you so much again for having me. I'll go over the trial, the rationale of why we looked at metformin. I'm going to focus on metformin results from this trial. Okay, so why metformin? It started with a biophysical engineer at the University of Minnesota, David Odie. He uses in silico modeling to identify proteins for cancer therapeutics, and he's well funded from NCI for this work. And early in 2020, his team developed a simulator for SARS-CoV-2 and used it to identify proteins that appeared important for viral translation. One of those proteins was mTOR. And then Chris Tignanelli used natural language processing to go through medical literature to identify existing medications that inhibit mTOR. And metformin has been known to inhibit mTOR for a while, so that was one of the medications he identified. And then as 2020 and 2021 went on, all of the predictions from David Odie's simulator ended up being correct. Metformin is a really interesting medication. It's a pleiotropic medication. In doing a really deep dive in the literature about metformin, I found that the earliest articles about it are actually in influenza and outcomes from influenza. It was FDA approved from diabetes in the 1990s, and then after cohorts of people were on metformin for years, people started noticing other benefits, potentially anti-cancer, anti-inflammatory actions. It was studied in vitro against other RNA viruses like Zika and found to inhibit Zika in vitro. And then even pre-2020, there were RCTs of metformin in other infectious diseases. But that's all fine. What is specific to COVID? And so what I found was there were some papers early on showing associations with people with diabetes who were taking metformin and less severe COVID. One of these papers showed that those on metformin had a lower IL-6 than those not on metformin. Chris Tignanelli, who did the natural language processing, asked me to help with an observational analysis. I think I was the only diabetes obesity researcher he knew, and so I helped with that. And then we found an association, not a strong one, but the data we used was claims data only. It didn't even have BMI, for example, in the data set. And then there was actually in vitro data. Oh, this figure did get messed up, but in a Nature article in February 2021, they looked at a whole host of existing medications, and metformin was one of the only medications to decrease viral growth, that's the red line, while improving cell viability. So anything can decrease viral growth, like bleach, but whether or not it also harms your cells is important. So, and then the only other medication in that figure was olanzapine, an antipsychotic that has a lot of side effects. So metformin, so that was all fine. I was a little skeptical of the antiviral actions of metformin, but I was willing to go along with David and Chris. And what I knew about metformin is that it's a pleiotropic medication. For a long time, we know it has these anti-inflammatory actions that seemed relevant to the pathophysiology of SARS-CoV-2, and now it seems potentially the pathophysiology of long COVID as well. And metformin is safe. It's tolerated. In a randomized trial, they gave metformin to people who had previously not tolerated it, and they were able to tolerate it. There's actually no increased risk of lactic acidosis in metformin. We're now supposed to continue it in people with renal failure, liver failure, heart failure. It should no longer be stopped at the time of hospital admission or perioperatively. And we give metformin in pregnancy and to children without diabetes. It does not cause hypoglycemia. That's not how it treats diabetes. All right, so it seemed there was in silico data, in vitro data, observational data, and it was safe. So in my mind, okay, fine, it made sense to do a randomized trial, and other people at the University of Minnesota had launched decentralized clinical trials, so the hydroxychloroquine trial, for example. So I was able to get their protocol and sort of use it as a guide and put together this trial. So it was a 2x3 factorial design, so 6 parallel arms of distinct treatments. The primary outcome was severe COVID by day 14. 14 days of treatment were given, except for ivermectin, which was only 3 days. And the key exclusion criteria, so they had to have documented SARS-CoV-2 result. We enrolled within 3 days. They had to be randomized within 3 days of that positive result. We didn't require symptoms to enroll, but if they had symptoms, they could not be longer than 7 days. And I did have a BMI minimum of 25, but 25 and up is 80% of the adult population in the U.S., so fairly generalizable, and excluded people with known prior history of SARS-CoV-2. And people could not be taking metformin at the time of randomization. So just a quick overview of statistical considerations. So the primary outcome was a binary composite outcome of 4 components: 1 low reading on a home oximeter, an ED visit, hospitalization, or death. So if a participant achieved any one of those things, they had achieved the primary outcome. Key secondary outcomes were excluding the oxygen component, long COVID, and outcomes at day 28. The primary analytic sample was a modified intention to treat. So this was done in other decentralized trials for COVID where we wanted to minimize contact, so the medication had to be delivered to participants. And so if someone didn't receive the medication, or the day or two later when they did receive medication, if they were hospitalized or no longer willing to take the medication, mostly because they felt better, then they were excluded from the primary analytic sample. And then we decided to impute missing data. The missing data for the primary outcome was only 1.4%, so we had very little missing data. And one thing that has confused people about this trial is people thought, oh, you have to correct for multiple comparisons for doing this parallel arm trial, but you don't. So the way to think about this is it's 3 separate trials, 3 randomized comparisons. Metformin, everyone in the trial had received a metformin pill or an exact matching placebo metformin pill. And then a subset were in the fluvoxamine trial or the ivermectin trial. We had exact matching placebo for all medications, and because there was an arm that had 2 active meds, 2 arms, everyone in the trial received 2 pills to maintain the blind. And it's just so this design is sort of like trialing new medications with background therapy, like in Strive. So that's all that is, but it was a little confusing to people as the results came out. All right, so we randomized the first patient on December 30th, the last patient on January 28th, 2022. The end of the 14-day follow-up was more than 14 days later. There was a blizzard that hampered delivery of that last batch of patients. But so we were unblinded and submitted less than 2 weeks later. That's all will become relevant later. But we worked quickly to get these results out, and this is the consort diagram in the primary outcome paper. I won't spend too much time on this here, but basically 94 participants were excluded from the modified intention to treat because they were hospitalized, didn't receive the medication, or felt better and no longer wanted to be in the trial or no longer wanted to take the medication. Okay, so this is table 1. It's very busy. The main thing to point out here is that everyone was in the metformin or metformin placebo comparison. We had about 56% of the sample was women, 6% of whom were pregnant. We had 52% of the overall sample was vaccinated, so we did not exclude vaccinated individuals, and 22% were enrolled during the Omicron period. So while at the time that felt like a failure because we hadn't finished enrollment yet, now I think it improves generalizability because we did enroll during Omicron as well. And I should say fluvoxamine was closed early by our independent data safety monitoring board because of lack of conditional power. All right, so here's the primary outcome results. One low oxygen reading on a home oximeter or ED visit hospitalization death by day 14. You can see it here in the modified intention to treat group on the top and the intention to treat group below that. Basically, they're the same. Confidence intervals are a tiny bit smaller when you have those extra 94 patients in there. And the complete case results were virtually the same, even actually a little bit more effective, but our statisticians imputed towards the null because they don't want to impute away from the null. And then an a priori subgroup was to look at those who started study drug within less than 4 days of symptom onset, because that was similar to new therapeutic trials, primary analytic sample, and immediate release metformin is available probably in most pharmacies in the world, so it's feasible that someone could start immediate release metformin within 4 days of symptom onset. And you can see the point estimate moves to the left in that subgroup. We never want to over-interpret subgroups. And then another important subgroup is pregnant women. So we had 3 hospitalizations in the pregnant women, in the 45 randomized pregnant women. None were in the metformin group. They were all in the placebo group. And then hospitalization or death by day 28, point estimate 0.42. So I presented these at a few grand rounds, one of which was at the Welch Center. I did residency and fellowship at Johns Hopkins, and you see these results. The primary outcome is the top row, the odds ratio of 0.84, and clearly that confidence interval is above 1. It's a negative clinical trial. We can't really do much with these results. We need a confirmatory trial. And the confidence intervals are wide, even the ones that are below 1. So I don't want to overinterpret results. But as I was presenting this, Larry Apple, the director of the Welch Center, said, "Hold on, no you don't. It clearly prevents severe COVID." And so I was like, well, that can't be true. The primary outcome was not statistically significant, and what does Larry know? But he is a big person with an impactful career, and he's a distinguished scientist, all that stuff. So I was like, okay, what does he mean? Well, basically, I made several mistakes with this trial. First, I didn't define the primary outcome well. So the hypothesis was good. Does early outpatient treatment with metformin prevent severe COVID? But the definition of severe COVID is bad. We now know that one low reading on a home oximeter, even with no measurement error, does not equal severe COVID. But at the time, there was this confusing, silent hypoxia thing where people are going to be dying at home and we might not even know it because they didn't make it to the ER. That's kind of why I thought, maybe this should be part of the definition of severe COVID. But it's not severe COVID. And according to Larry, I didn't interpret the application of this data correctly. So is he right? So I tried to find guidance in other places. JAMA has a nice podcast about this, actually. So they made an analogy that multiple comparisons. So your intervention is the person. Your hypothesis is this person a professional archer? a professional archer hits a target at 100 meters, so that's your outcome. The analyses are the number of arrows you get to throw at the target. The p-value is the size of the target. So this is all set up in this JAMA podcast. So if you're going to throw multiple arrows at that target, you should make the target smaller and have a smaller p-value. But what if you just define the outcome incorrectly? That's what Larry was saying, because actually the p-value for ER visits, hospitalization, death would withstand a test for multiple comparisons, but Larry was saying I didn't even need to do that. I just didn't define the outcome very well. So, so basically I made the distance to the outcome not right. So anyone can hit a target at 1 meter, even if they're not professional archers. So anyone can have a low reading on a home oximeter, even if they don't have severe COVID. So that was the issue with the outcome. And anyway, at least according to this podcast, sure, that seemed to make sense. Maybe he was right. And his point too was that with the same exact data generation process, you do have the right outcome. ER visits, hospitalization, death. And we obtained source documentation of all ER visits, hospitalizations, death. Of course, we couldn't confirm the oxygen readings. Those were purely self-reported by the participants. Okay, so mistake 3. Publishing all 3 medications in the same paper meant that I couldn't actually visualize the data. So Larry made that statement after seeing this this forest plot, at least a visual representation of the numbers that I put together for the Welch Center presentation. But this is the only results in the primary outcome paper, is this really busy table. So all of this data is in the primary outcome paper. All of those numbers were published in the same paper, but this is how they were represented in the paper. So it's impossible to see that data, and I realize that now. At the time, I thought it was important to get all of the 3 of these medications published as soon as possible. But as I looked at other factorial design trials, they often publish each medication separately because that allows the space for presenting the results that you expect to see from a phase 3 randomized placebo-controlled trial. So this is one example from 2018, so pretty recent, and you have to look really hard to find that this trial is a 2x2 factorial trial. Ours was a 2x3 factorial trial, but they published each medication completely separately, and that allowed the depth of presentation of results. They have secondary outcomes in those papers, even post-hoc analyses in those papers. So that was, I think, a big mistake on my part. Okay, so, but the other question, is Larry right? Sure, maybe, but how does this align with other data external to our trial? So these folks at Jackson Labs have this big computery thing where they predict medications, and metformin was one of the best ranking medications. You can see it all the way over there on the right as one of their best predicted meds for COVID. And then they did an observational analysis, and you can see all these point estimates are way, way, way to the left of 1. So, and there are actually a lot of observational papers right now. You do have to be careful when doing any pharmacoepidemiologic analysis. You have to condition on the indication, so restrict it to people with type 2 diabetes or without type 2 diabetes, but there are a ton of observational papers out there showing an association with less severe COVID-19. There was a study published before ours in December 2021. So the Together trial stopped enrolling on their metformin arm early in 21, pre-Delta. They enrolled in Brazil, so it was mostly gamma, pre-vaccination. So for those reasons alone, our trial was more relevant. It was post-Delta vaccination, Omicron. They use extended release metformin, which doesn't have as much systemic exposure as immediate release, so the formulation they used was not as good, and they didn't have any dose titration. And that would cause side effects in everybody if you went right to 1,500 milligrams a day. But the intervention was also not randomly distributed. They enrolled people already taking metformin, so we really can't interpret this as a randomized trial because the intervention was not randomly distributed, and giving a huge dose of metformin on top of an existing dose would cause side effects. But all their data is also to the left of one, so at least consistent direction. And there has been a phase 2 trial now published showing that metformin also prevented severe COVID in this trial and their virologic outcomes. Okay, so adding those into this same forest plot, this is that phase 2B trial, kind of consistent. At least all these odds ratios are in the same direction. They're kind of the same magnitude. This is the viral load results from our trial that I presented at CROI. And how can that be true if diabetes is such a big risk factor for severe COVID? I'll speed up here, but basically, the New York Times made a big statement about this, but why is this a big deal? Like, that's basically the prevalence of diabetes in older adults, and those are the ones dying of COVID. So we looked at decedents of influenza in Medicare data pre-COVID, and 61% had diabetes, 63% when you age match it to COVID decedents. So in fact, a lower percentage of the decedents from COVID have diabetes than influenza. I don't think we should make strong conclusions about this, but the sensationalization of diabetes deaths from COVID was wrong. All right, so long COVID. So just quickly, I added long-term follow-up data to the protocol in spring, summer 2021. I really had no idea how to define long COVID, what questions to ask. Some people had already completed the trial and were not consented to an additional 9 months of surveys, so that's why the number is a little bit smaller. So here is the primary outcome result. Some were lost to follow-up, some died. Then of those 1,304, some we were not able to reconsent because they had already finished the trial and they didn't want to do more surveys. Some we had lost follow-up to, some withdrew. So basically, we had 1,126 who filled out the results for the long COVID outcome. And the only a priori outcome that I had was proportion of individuals with long COVID. We assessed that by asking if a medical provider had diagnosed them with long COVID, and if so, when, and what type of provider. I'm sure there are many critiques of this way of ascertaining long COVID, but I think it was a good balance of sensitivity and specificity, especially at the time. Overall, 8.4% responded that a medical provider had diagnosed them with long COVID. Most of those were from primary care providers or other specialists, as you can see here. And then when you look at the comparison between metformin and placebo, those in the metformin arm were less likely to develop long COVID than those in the placebo arm. We did also ask about surveys on our symptoms on all of those surveys. So I have all of this data too about what specific symptoms they were feeling. I had no a priori outcomes about the symptom data or how to define long COVID based on symptoms. So this is in the paper, but we haven't looked at whether or not metformin prevented the symptoms yet. And then if any of those symptoms affected their ability to work or leisure activities. And only 3.8% reported receiving a treatment for long COVID. So as we've all seen, there's an urgent need for long COVID treatments. All right, this is being a little slow. There we go. So what to do with all this data? I think, what does all this data mean? This is that same forest plot, and then now I've added in that long COVID outcome. And then if you look in the same a priori subgroup, those who started it within less than 4 days of symptoms, the point estimate again moves to the left, and that's consistent with an antiviral mechanism, which is consistent with the antiviral data. But should we even consider long COVID as an outcome in a randomized trial? Again, going back to this podcast, they said, if you ask a separate research question with separate data, you don't have to correct for multiple comparisons. So The long COVID is like asking, is this same person, is this same intervention a professional basketball player and not a professional archer? So yes, I think we can take the long COVID result into consideration as we interpret these clinical trial results. But it is still negative clinical trial. It makes me really uncomfortable to interpret it. I'm getting my K-23 training plan involves getting a PhD in epidemiology, which seemed like a great idea pre-COVID, but now I'm struggling to catch up on that coursework. But I really want to interpret the data correctly. But as I, again, looked at what Larry was saying, there are data or opinion papers, reviews to support that, yes, you can make treatment and guideline decisions based on a negative clinical outcome. And they give example of existing medications being added to guidelines with a negative primary outcome. All right, so all this is to support preventing long COVID. None of this data says that metformin treats long COVID. I think that we should start preventing long COVID by using metformin as early outpatient treatment of acute COVID infection, and that it fills a gap. There is nothing in the treatment guidelines for patients at standard risk. Remember, we only excluded those with a BMI under 25 or age under 30, so we only excluded low-risk individuals. And we need lots of RCTs for long COVID treatment. I would love thoughts on what patient-reported outcomes should be for long COVID treatment trials. Again, while I think the mechanisms of metformin could support studying metformin for long COVID treatment, this data only supports metformin for preventing long COVID. And the great thing is that metformin doesn't interact with many of the therapeutics for acute treatment, proposed therapeutics for long COVID treatment, so we can use them in combination. And I'm more of a chronic disease clinician, and in this clinical review that we recently did, you can see that we have a whole host of repurposed medications, meds based on secondary outcomes from clinical trials that you have to work really hard to find those outcomes. And just like these other diseases, I think the world needs many treatment options for long COVID. So thank you very much.